recording. All right, we got the lovely Dr. Saada here to give us a talk on emergency management of brain injury following cardiac arrest. Take it away.
Okay, thank you guys for having me here. Good morning. We had to reschedule from yesterday because we are hardworking people, you know, although it wasn't my fault, it was Dr. Pinicar's fault. But I appreciate what you guys do. So the goal here is what we are trying to do is what we want to achieve is to improve the outcome for the patients that come in with hypoxic ischemic brain injury. You know, we are a cardiac hospital, and what we really want to do is to see how we can achieve more discharges of patients that can actually be independent. You know, so we're gonna try to review some pathophysiology here and go over data and tools to help with prognostication. The issue about the talk is this is such a wide range lecture that I think, you know, a series of this over the years can be helpful because we can specifically discuss things like cardiac arrest and EEG findings, cardiac arrest and prognostication, cardiac arrest and brain death, right? So many things, cardiac arrest and seizures in particular. So in this specific talk, I'm going to pretty much touch base on points, kind of small objectives of little topics, so we can eventually dive in one day and take it one topic at a time. So before I start with the lecture, I wanted to discuss a case real quick, just a case presentation of the typical cases that we see. A 55-year-old woman who was found without a pulse. Her husband performed CPR. EMS arrived and she was defibrillated and had return of spontaneous circulation after a total of 15 minutes of CPR. Initial EKG showed non-ST segment elevation MI. On examination, she didn't open her eyes to stimulation. She had intact pupillary, corneal, and oculocephalic reflexes, demonstrated spontaneous respiratory rates above the minimal ventilator setting. She did not have a cough or gag, and had extended bilateral upper extremity responses, so Babinski positives bilaterally. Her CT of the head showed no acute findings. The neurologist and interventional cardiologist discussed her case. She underwent cardiac catheterization that revealed 100% occlusion of her left anterior descending artery. So she was started on a TTM, temperature control target about 36 degrees. Her mean arterial pressure goal was more than 65 millimeter mercury because she was in severe shock. So that was pretty much treated. Her EEG did show continuous background with generalized periodic discharges at 2.5 hertz. So quite significant finding, consistent with an interictal continuum. So this is one of the findings that are concerning when we see on EEG. But there was some reactivity on the EEG along the way. She was on propofol, Keppra, Depakote. Over the next 48 hours, she remained in a coma, but regained some of the brainstem reflexes. She flexed her bilateral upper extremity, developed stimulus-induced myoclonus. Her EEG continued to show generalized periodic discharges, but had no correlation with myoclonus, so she wasn't having seizures. We added clonazepam, and you know, her EEG improved a little bit. 72 hours out, she had slight improvement in her neurological examination, but 5 days out, she was still really not waking up. We went ahead and did MRIs, and the MRI did show some cortical diffusion restriction in the occipital regions. And we discussed her care with her husband, who wanted everything done, and she was trached and a peg was placed. And over the next 3 months, she received almost like she went to an inpatient facility and received the care she needed. And over 3-month period, she actually started regaining consciousness, and she was left with myoclonic jerks, but was awake. She was able to actually remove the tracheostomy. She was able to have the PEG tube removed, and she was discharged eventually to home after 4 to 5 months. So these cases do exist. And she was a young patient, right? She was 55 years old. So aggressive management. So these are things that we go through every day, and hoping that we can figure out a way to, which we do every day, provide these patients with options and choices, and you know, if there's possibility keeping these patients alive to recover, that wouldn't be a bad idea depending on the case scenario. So epidemiological facts here: 150,000 people come to the hospital with cardiac arrest that receive RUSC. More than 150,000 are admitted to the hospital. Survival to hospital admission via EMS is about 27%, which is surprising because I think we see a higher number than that. And then RUSC is achieved in 70%, this should say, with in-hospital cardiac arrest. So if a patient has a cardiac arrest in the hospital, they're more likely to receive RUSC compared to patients that are coming in from outside the hospital. So that's consistent, right? That makes sense because, you know, depending on how long these patients were down for, this is when we would say, okay, this is going to be a good sign or a bad sign. In the hospital, they're on tele and nurses are checking on patients, so we are able to achieve a higher RUSC. This slide here, we can pretty much use the bottom part of the slide to think about how to prevent a certain damage, and the top part is the mechanism of the damage that takes place. So you have a healthy patient that is dieting, exercising, has a defibrillator nearby, and is on aspirin, statins for risk factors of cardiovascular disease, right? They collapse all of a sudden, they become pulseless, and this is where the mechanism of the injury takes place. So as soon as a patient has loss of blood flow to the brain, this is their primary brain injury, right? We have the pretty much ATP function, dysfunctioning, energetic failure, and oxygen depolarization, some disruption in the blood-brain barrier. And our goal is to minimize the second step that's going to take place, right? Secondary brain injury. The primary brain injury is the ischemia that takes place. So how do we do that? High quality CPR, early defibrillation. You treat any reversible causes, and you know, supporting them with ventilation. And RUSC is pretty much received. They're transported to the hospital. This is where the somewhat of a biggest problem that takes place because of depending on the prolongation of hypoxia / ischemia, right? How long are they, you know, being transported with a blood pressure of 50, 60 over 30, right? So secondary brain injury takes place, reperfusion injury, and patients are coming in the in the ICU, and they are receiving this care here that we are going to discuss. How do we prevent rearrest? How, you know, we maintain cerebral perfusion, maintaining good oxygenation? Do we treat, not treat edema, cortical hyperexcitability, or if they're having seizures? We want to prevent fevers, and we want to take our time with prognostication so we don't have any false positive prognosis. Then the patients are discharged and they receive cardiac brain rehab. And this is where they come in clinic, and, you know, Mrs. Smith is complaining about Mr. Smith that his memory is not the same after his cardiac arrest, and he's not able to do certain things, and he's depressed and so forth. So it's a process. It's a multidisciplinary approach and a process that takes place. And it's not a one-time, you know, 1 week and patients they're back to their normal self. Now, the primary brain injury that takes place is, again, usually caused by ischemia during the pulselessness that takes place. So you have inadequate cerebral oxygenation, causes neuronal ischemia, cell death within minutes. You know, depending, each patient is different, of course. If a patient has good collaterals, right? If a patient works out, then they can sustain a prolonged ischemic episode, right? But if a patient has all this cardiovascular disease, peripheral vascular disease, and a slight drop in oxygenation to the brain, it doesn't even have to be complete cardiac arrest, can affect them long term. So This process takes place. We get the patient back due to ROSC, due to the EMS doing CPR and achieving ROSC, and then they develop the secondary brain injury. And the secondary brain injury really occurs because of this reperfusion injury, this inflammatory response, this disruption in the blood-brain barrier, this push in of blood into these damaged vessels, these microvascular injury that takes place in the endothelium, and that's how they start leaking, right? That's why sometimes with reperfusion injury, we actually see hemorrhages and all this edema that takes place because of this process that takes hours to days after the injury. The longer the secondary brain injury occurs, the worse the outcome. And how do we minimize it? Well, as soon as the patient comes back to life, we want to avoid certain things, right? Avoid fevers, avoid seizures, treat infections early, balance their oxygenation delivery and demand, and this would help. Now, let's say the patient had a cardiac arrest and it took within minutes to return to spontaneous circulation. They could still have an anoxic brain injury or hypoxic ischemic brain injury because there are parts of the brain that contains this dense synaptic network that requires constant oxygenation, high demand for oxygenation. These parts are the hippocampus and the temporal lobe, and the Purkinje cells in the cerebellum itself. And that's why sometimes those are the areas that show up on the CT, right? The cerebellum swelling if a patient was down for an hour or so, because these are the areas that really get hit first. And that's why patients can have memory problems despite being, having a cardiac arrest for like 2-3 minutes, because those areas really require high oxygenation. The mechanism of the injury in these patients usually are cardiac related, right? The patients with coronary syndrome, arrhythmias, cardiomyopathies. So 70% of patients with cardiac arrest have cardiac related pathology, respiratory mechanisms, COPD exacerbations, patients overdosing and having hypoxia. And rarely do you see actually primary neurological injury other than, subarachnoid hemorrhages, and patients that could have, actually, I probably see this more than any intracranial hemorrhage, like sudden unexpected death of epilepsy, patient going into epileptic patient having a seizure, and the seizure, you could argue that it's actually a primary cardiac issue, right? Because they would have an arrhythmia, or a secondary cardiac issue because the seizure caused an arrhythmia and they have cardiac arrest. That's seen in about 4% of patients with epilepsy. So keep that in mind. And the auto-regulation curve, this is one of my favorite curves that graphs that I show. So what we have here is we have this cerebral hypoperfusion that takes place, and that will disrupt the auto-regulation in the cerebral blood flow. So as you can see, a normal person, me and you sitting right here, our blood pressure, our MAP can go down to, 60, and we should be okay with the cerebral blood flow perfusing. We need at least 50 to avoid any ischemia, right? So immediately after the cardiac arrest, for some reason, these patients would have a right shift in this auto regulation in the cerebral blood flow, which means if their MAP is actually 60, this is bad for them, right? Because a MAP of 60 will get you a perfusion cerebral blood flow of around, 30, which is the area where that's an ischemic range. So some of these patients have this right shifted graph, plus because of like chronic hypertension. If they have chronic hypertension or some of these risk factors, this will shift towards the right, meaning they just need a higher MAP to perfuse their brain. Remember, cerebral blood flow is the MAP minus the intracranial pressure. So if you have a high intracranial pressure and a low MAP, the cerebral blood flow is going to be extremely low. And that's how you develop ischemia. So we want to make sure our MAP is usually, if we go back to the other slide, some of the observational studies looked at this actually and said, hey, you want to have a higher MAP, but a higher MAP means something greater than 80, less than 100 would be reasonable. Of course, just having a high blood pressure is not going to affect the entire picture here and have a favorable neurological outcome, but a MAP of a higher MAP such as 80 will be one of the factors that can improve outcome. And this is interesting actually, because a higher MAP was associated with a lower level of the neuron specific amylase that we would check. So patients that have constantly a higher MAP will end up having a lower brain damage long term. So that's that here. Another thing we want to prevent always is making sure the patient, as a non-pulmonologist, non-critical care doc, I, would always think, hey, why can't we just deliver some oxygenation to these patients, right? High oxygen. Actually, high oxygen can hurt the brain. A study looked at this, and they looked at this by directly measuring brain tissues oxygenation and found that some patients with recoverable hypoxic ischemic brain injury develop diffusion limited oxygen delivery because of the swelling that takes place, the perivascular edema that takes place. So even delivering high oxygen isn't going to help these patients. So severe hypoxia, of course, we want to avoid. But the optimal, this randomized control trial looked at this and said the optimal oxygenation would be between 75 to 100, right? Hypoxia, don't deliver too much oxygen, but somewhere between 75 to 100 is the target. And just like the temperature, just like the blood pressure control, this is not the only factor that's going to improve the outcome. The constellation of all these little interventions would hopefully give us a better outcome. And of course, as we know, hyperventilation will lead to low CO2 levels. So then what happens is we're going to have cerebral vasoconstriction. So really, long term, when these patients are intubated, norm to mild hypercapnia can improve cerebral blood flow because a little bit of hypercapnia will cause vasodilation and better perfusion of the brain. Prevention of rearrest, that's an important topic here, because one of the common trials that they looked at a few years ago too said that a patient, 20% of these patients can have rearrest within minutes, and that right away is associated with a worse outcome. Patients with less severe injury, of course, will have a lower risk of rearresting. So what does that mean? That means if a patient has a small PE and for some reason went into this arrhythmia or some type of pneumothorax and immediately that was fixed, these patients should have better outcome than the patients that's coming in with a STEMI and it takes 3-4 days to fix and they're constantly arresting eventually. This isn't good for the patient. So discovering the etiology early and treating is the goal here. Temperature control, this was a big topic like 10 years ago, right? Should we induce hypothermia in these patients? Well, we know hypothermia reduces the cerebral metabolism, alters the apoptotic cascade, improves glucose control, glucose use, and reduces seizure tendency, lowers the ICP. But over the years, we've realized that really just a target of a temperature between 33 to 36 degrees Celsius is the way to go. 36 degrees is fine. Just avoid fevers. Actually, the problem is also rewarming would be a problem in these cases. So if you have someone at 33 and then you rewarm them quickly, then there could be potential worsening outcome than getting someone to 36 and keeping them for a few days in that degree. So avoiding fevers is the key here. The next topic is seizures and hyperexcitable EEG changes. So what does that mean, hyperexcitable EEG changes? These are patients that have non-epileptiform changes that are seen on EEG, such as generalized periodic discharges, right? Periodic lateralized discharges and so forth that are not really seizures, but are showing signs that the cortical part of the brain, the pyramidal portion of it, is active and it's irritated pretty much. And why that occurs is because we have a disruption in the glutamate and GABA receptors, and we have more glutamate being triggered, and therefore that's an excitatory response that we get on the EEG. So believe it or not, actual Generalized tonic-clonic seizures are not commonly seen. 10% of patients that come in with cardiac arrest have generalized, where we see a constant seizure on the EEG and they're constantly convulsing. It just doesn't work that way. Most of the patients have a continuous background. What does that mean? A little bit of theta, delta, depending if they receive sedation or not. And there are cases, though, of myoclonus and non-convulsive status. So why do we want to do EEGs on all these patients that come in? Because we don't want to miss non-convulsive status epileptics, which can be seen between 10 to 25% of cases after cardiac arrest. Differentiate myoclonus versus epileptic seizures. Well, myoclonus is actually not associated with an ictal pattern on EEG. It's not associated with seizures on EEG. It's just, again, a hyperexcitable response that the brain does after a cardiac arrest. And we treat those similarly because we don't want the patient to constantly shake and have these discharges. And in some instances, myoclonus can progress into an ictal pattern. So we gotta keep that in mind. So while myoclonus was commonly seen as a poor prognosis, recent studies actually proves that myoclonus alone does not invariably predict poor outcome. That's very important to keep in mind, okay? Patients with myoclonus are at high risk of a condition called Lance-Adams syndrome, which after days to weeks after the patient does wake up, they could still have this little shakes. Medications such as clonazepam and Depakote are really good for this condition. Neuroprognostication. This is the topic that we are going to spend some time on now. So every patient is different, right? You could have a patient that's very healthy, that's young, that has cardiac arrest, and they do well, or they have evidence of brain injury, but we continue to be aggressive managing them because they could potentially do well in a few months. And you have the 85, 90-year-old that, you know, they just have the cardiac arrest and leave us peacefully. And it is vice versa, actually. I've seen patients that are 85 tend to do well because of the slight shrinkage of their brain, so they can afford a little bit of swelling in the brain, and they don't have significant brain injury from their cardiac arrest. So in a single center study, here's the scary part. Clinicians incorrectly predict both survival to hospital discharge and awakening from coma in 1/3 of cardiac arrest cases. So this results in thousands of avoidable deaths annually. Again, we have the vice versa. Incorrect predicting potential for awakening, thinking that the patient's going to wake up and they're going to do great, is also seen and can unnecessarily prolong the patient's life and can be costly for the patient, for the medical system, pretty much. So life incompatible with the patient's previously expressed wishes is also seen. So no gold standard approach to prognostication, but of course our goal is to reduce the false positive of unfavorable outcome. This is a table or a approach that we can do. This is the Miracle 2 risk score is used by cardiology often here. And this came out around 2020, 2021. And what it really looks at is it is used as a decision making for early coronary angiographic assessment. So if a patient scores low, then they are going to have a better outcome later on. So they need to have a angio done, right? A cardiac angio done. So if a patient has a high score, then you got to be careful because their outcome is going to be poor anyways. So you can hold back from doing the angio. Here's a cool retrospective data that looked at this actually. 148 patients underwent early angio, no matter what their prognosis was going to be, right? This was done in a facility. And what they found was right away, if a patient has a Miracle 2 score of 2 or less, their likelihood of recovering and doing well is above 95. This study said 97. One study said 94. So it's pretty high that they're going to do well. If they have an intermediate risk, which is a score of 3 to 4, their likelihood of recovering, having a functional neurological recovery. By the way, this is monitored by a modified Rankin score of less than 4, right? You could use a cane, which is 3. 4, you're using a walker. So that score was about 50%. But if you have a score of 5 or greater, your chance of recovering is like, 9%. Score of greater than 5 predicted poor neurological outcome in another study in about 97 with a specificity of 97.5. So there's a low false positive prediction there. So that's pretty cool. So it is used to guide decision making. Overall, I think 2024 now, it has a high accuracy for determining neurological prognosis. There are at least 4 or 5 studies out there that looked at this, over 1,000 patients, and it is comparable to other scores like the cardiac arrest hospital prognosis score or the out of hospital cardiac arrest scoring or even the TTM scoring. It really does compare well with it. So that's currently being used. Another thing that I wanted to add or use here is something similar to the GCS score, but this is the 4 score response. It's an older scoring system. Pretty much, I think it came out around 2010, and it remains effective since 2019 based on some of the journals out there. The Circulation Journal, for instance, uses the score and brags that it still works if we get rid of the respiration part, which you can see that respiration part isn't really that helpful, right? A lot of our patients are going to be intubated anyways. So overall, this score system is used to monitor patients' progression. That's what I would use it for. So patient comes in with a high or with a low score, and then all of a sudden the score changes and it becomes better. Well, they have a chance of a good prognosis overall. That slide kind of went in there. It should have been earlier here, but okay. So then you mix the 4 score with the Pittsburgh post-cardiac arrest category severity score. This was a study done on 317 patients that were studied, and it is a retrospective analysis, and the patients really were all different. There were younger patients. I think the oldest patient was like 62, 63 with the mean age of like 59. So what they really looked at is they took the 4 score and they associated each category with certain examination findings, certain characteristics of the actual cardiac arrest, and gave a number of, okay, out of 317 patients, this is how many patients survived. This was their outcome. So good outcome is defined as a modified Rankin score of 0 to 3. So a patient can have a 3, they're walking around using a cane at like 6 months or so. So what you can see here is you can actually pick and choose the category and say, okay, my patient is coming in with, a PCAC of 3. So their overall survival is like 40%. The only problem is you're going to have some characteristics that are going to be in the different categories. So how do you mix and match, right? So overall, okay score to use. This had a specificity of a worsening neurological outcome. If they score, for instance, a PCA4, the specificity was like 88%. So it's up there. It can be used. But this is why we have all these other tests, right? So I wanted to include this just so people can use this as a reference. The neurological testing that we have, this is part of our continuum journal that we use. These are things that we can take and use all of these to pretty much come up with a conclusion of how the patient is going to do, right? If a patient comes in with a 4 score of a low 4 score, sure, the prognosis is bad, but we got to keep in mind that there are factors like, a poor motor examination is really no longer considered specific for poor prognosis. So we got to keep that in mind. So, but it can be used to say, okay, well, the force score is low. That's not good. The EEG is showing a pattern of, epileptiform discharges, suppression. That's not good. A highly malignant EEG pattern might evolve over time. So you got to be careful with just using one EEG pattern. We don't do the N20 responses here because of the artifact. I mean, these facilities, ICUs, are really built to do nerve conduction studies and neuromonitoring, but ours is not. I mean, we have so much artifacts that we're unable to really do this here. But chemical biomarkers can be helpful, right? Get a neurospecific analyse, high concentration of 48 hours or 72 hours, is usually correlates with a bad prognosis. Usually you want to trend this. We don't typically trend it because by the time it comes back, we're going to have, the patient has declared themselves or we've got a decision with the family, right? Other thing, go ahead.
Ask you what your honest opinion on it is, because I have found it to add almost zero.
I know, Josh.
I've seen it 200 and the patient wakes up.
That's right. I have too. I have. So I don't, be careful. Is it because we got it too early sometimes? Did we get the neuron specific analysis on day one when the patient arrived? We should technically wait. And again, this is the notes that says you got to trend this over 3 days. You got to get it 48 hours, 72 hours, 96 hours, and see how the trend is going. And if the trend is going up, this is a bad sign. But one neuron specific analysis shouldn't really give us answers. And it's scary, right? When patient does pass away and then their neuron specific analysis comes back normal after a few days, what does that mean, right? They were brain dead, right? So yeah, definitely it doesn't correlate very well if you just get one level. I feel like these are the best tests, and I clinical judgment and history is very important, but this is very helpful too, right? If a patient doesn't have MRI evidence of diffuse and extensive anoxic injury, cortical ribbing, basal ganglia hyperintensities, cerebellar hyperintensities, temporal lobe having some changes, then their brain injury is not severe. That's how I would say it. And more time is needed, right? So, of course, we know CT of the brain is going to be pretty much normal in the first 24 hours in a majority of our patients, right? And this is very helpful if a patient is down for several hours a day. I don't know how they got resuscitated, but they've got a beating heart, but their CT is terrible. It shows severe edema, it shows changes consistent with an anoxic brain. That is extremely helpful because we can say that this is not going to look good. Of course, you got to give the patient some time, but more time for these patients, what I find is they will progress into almost brain death. So
would you agree that if your CAT scan at any point shows signs of edema, there's not really any benefit? Because I found sometimes people reflexively order the MRI, but you already have CT changes. You're
right. Yeah, and try to educate the family that no, an MRI is unnecessary because we already have evidence on CT. Yes. Yeah, I do. I would use the CT as equal as to the MRI. It's not gonna show anything, especially if the history fits perfectly, right? Overall, this should give us an idea of what to do, right? If a patient comes in and we initiate TTM, which 36 degrees is more than enough of hypothermia. Then patient is unconscious, right? M less than or equal to 3. So these are medical issues that are going on. You got to have less than 3 factors. For instance, patient is on sedation. Patient has an ammonia of 150, 200, and patient's creatinine is 5 with a BUN of 150. Well, these are not less than 3 factors, and the patient's temperature is 93 degrees. No, you got to wait till the other confounding factors are less than 3, and patient is at 72 hours, okay? If they have at least of the 2 of the following: no pupillary or corneal reflex at greater than 72 hours. By the way, this is from the European Resuscitation Council prognosis guideline. If they have bilateral absence, well, we don't use this here. highly malignant EEG at greater than 24 hours. You see how it's greater than 24 hours? Because the first 24 hours, by the way, guys, the EEG measures the most superficial cortical layer of the brain. And you could have someone that has brain death, literally they're brain dead, first 24 hours, but still have a little bit of delta and theta on the EEG. Well, yeah, because the cortex hasn't completely, the neurons all the way distally haven't completely died yet. So that's why the EEG should be at least, we should get early EEGs to rule out non-convulsive status. But if we're going to use EEGs as part of the prognostication, it should be later on and off sedation. NSE greater than 60, we just talked about how useless this is because we're not even going to have this at 72 hours. Status myoclonus less than 72 hours. See, this is the end here. Because to be honest with you, if you have this and this is going to be most likely a poor prognosis, right? If you have clinical evidence of neurological deficits, especially no pupillary or corneal reflexes at 72 hours and diffuse brain injury, this is most likely a poor prognosis overall. And if you don't have that, then you observe and reevaluate. Now, from that study itself, actually, this is a group of critical care docs, Sandroni, 2021 study. What they looked at, it's an extensive, they did an extensive systemic literature reviews, 30,000 articles they looked at, and they found 939 comatose patients that underwent all the necessary neurophysiologic testing, biochemical testing, clinical examination, documented really nicely, and found out that after 21 days, these are the long-term outcomes in these patients, right? Multi-organ failure in about less than 10% of patients. That's why they pass away. This is patients that died. Pretty much almost 45% of patients will pass away. Cardiac related, right? Rearresting arrhythmias and so forth. And then cerebral death, so brain death. So this is almost more than what I usually tell families. There's the 10% rule, right? 10% of patients will wake up right away within 24, 48 hours. 10% will unfortunately be pronounced brain dead, and 80% we have no idea what's going on. This one, at 21 days, eventually patients will develop cerebral brain death. So cerebral edema, they develop herniation, they develop some hemorrhage, or they develop just brain death from the cardiac arrest and anoxia. Awake patient in up to, I would say almost 50, 55 or 45% here. And unconscious patients after 21 days, those are the hardest ones, right? Minimally conscious state, persistent vegetative state eventually after 30 or 90 days. So in a small number of patients, that's what happens. So overall, what does this mean, really? This means that there are some patients that at day 4 can be here, and eventually at day 21 can be here, right? So my recommendations is to, continue treating patients post cardiac arrest with intensive and aggressive care like we do every day. Focus on the prevention and treatment of both primary, mostly the secondary brain injury, right? We can't control the primary one because that occurs outside the hospital. Correct many of the pathological process that develop hours and days. No fevers, making sure infections are treated, seizures are treated. And us neurologists, we need to continue using this multimodal approach to prognostication, and acknowledging that no one approach is perfect. Every patient is different, and we would have different outcomes in different patients. But the goal is to prevent false positives overall. You use all the clinical, biochemical, neurophysiologic, and radiographic testing that we have available. And this is where eventually we can discuss brain death later on, and what tools to use, when do you use it, in terms of the perfusion studies and so forth. So that's all I have for today. I think Jackie's on the line. Jackie, are you on the line? Oh, sorry.
Any other questions? Not. Thank Thank you, Dr. Saada.
Well, thank you guys.
I guess
Thank you for
you've
having me.
already offered to have a series for us, so we'll take you up on
Let's
that.
do it, man. Let's do it. This is
Lots
fun.
to learn. All right, let's, recording here.
Is it okay if I share my screen, Dr. Pitakaru?